webinar for all of our members today. We are going to be talking about the most important aspect of our profession. What is defining us as a community health worker? We're going to be looking at the core competency. So welcome everyone, and hope you enjoy. Please ask all the questions, and Bernadine is going to provide you more information on this. But again, just want to say welcome everyone today. Bernadine.
Thank you, Flor. Good afternoon and welcome to the CHW Core Consensus Project webinar, and that's C3 for short. This webinar is being recorded, so if you're not comfortable having your camera on, now's the time to turn it off. So my name is Bernadine Muvunga-Jerry-Nyama. I'm the Senior Communications Associate at the National Association of Community Health Workers, NACHWA for short. NACHWA was founded in April of 2019 after many years of planning and advocacy among CHWs and allies from across the country. Our vision is to unify a workforce of community workers across geography, ethnicity, and sector, supporting communities to achieve health, equity, and social justice. If you are not yet a member of NACHWA, please visit our website. That's www.nachwa.org, NACHW, to learn more about our organization and the benefits of membership. We are also on Facebook and LinkedIn, and we are newly on Instagram and Twitter. So please follow us on social media to stay in the loop about announcements and opportunities. NACHWA does not create, facilitate, or endorse any CHW programs, but we do serve as a platform to highlight and connect programs to the CHW workforce. And I will now hand it over to Kim J. Oh, and also, as we go through the presentation, if you have any questions you'd like to ask of the host, we will be doing Q&A in the last half hour. So please place your questions in the chat and we will circle back at the end and ask them. And so now I turn it over to Kim J.
Thank you, Bernadine. Welcome, everybody. It's so great to see such a vast audience joining us this afternoon or this morning, wherever you may fall in this timeline. I just want to give an introduction about today's webinar that we are going to be talking about the CHW Core Competencies, as Flora already alluded to, the C3 project. And with this information, we're going to give you the origins of C3, why it's so important, the application of these principles of training and education, and then how we've been able to incorporate these into specific trainings and education sessions. We are so delighted to have such a robust panel of such excellent minds that are going to be able to share this information with us. So we welcome you to relax and just really be involved in the conversation. If there's anything that you are having any questions about or want more detail about, please use the chat. It is your friend. We are watching it to make sure we answer your questions. And so we want to get started. So now I'm going to turn it over to Paige Menke. Paige.
Hi, thanks, Kim J. Actually, I think Lee is going to get us started. So I'm going to throw it back over to Lee.
Awesome.
Okay, thank you, Paige, and thank you, Kim J. I really am delighted to be here today. Actually, just when the pandemic started to unfold back in February of last year in all our lives so fully, I think is about when Flor and myself and Denise Smith started to talk about how it'd be great to chair the C3 project in some way through NACHWA. And so here we are, I think, at another moment in the pandemic when we're seeing a lift and a rise and somehow completing that mission. And I really thank Bernadine and all of the organizers for putting this together today, and a great opportunity to share with you. My name is Lee Rosenthal. I'm based here in El Paso, Texas at the medical school, Texas Tech's medical school, and soon at a dental school where I teach public health. I direct our society, community, and the individual course. And my work in that environment is just over the past 5 years, but my work within the community health worker field as an ally has been ongoing since the late 1980s. And in fact, sort of began when I had an opportunity to return to Tucson, where I was from my graduate training in public health, to work with the rural health office there at the University of Arizona for 6 months. And that's actually when Floridea Redondo Martinez and I met, among many community health workers in Arizona and New Mexico. in the Southwest, where I began learning really about the community health worker field from peers in your work who are community health workers and allies and researchers and advocates. I think all of us using that umbrella term allies to think about the work we do in partnership with community health workers in order to bring this frontline workforce forward and be as strong as possible to support the underserved, often left behind communities in our country, to think about where community health workers fit in all spaces and places. And it's been my honor to work both back in 94 to 1998, directing the National Community Health Advisor Study, which was funded by the University of Arizona, by the Annie E. Casey Foundation and conducted through the University of Arizona. And then from 2014 to 2018 to direct the National Community Health Worker Core Consensus Project. And you see all those C's with their strong letters. This was a community effort. There's no question that everything we did to carry forward this project involved touching as many lives as possible, community health worker leadership and voice, ally insight and contribution. And it was really a team sport. It takes that village to raise a process forward. And that's really what we did in 94 to 98 and continued in that vein in the Core Consensus Project, which was really revisiting some of the lessons learned from 94 to 98 to see what are the roles and competencies that are driving the field today versus 20 years prior. And I do want to mention a few people to acknowledge, in addition to Paige Manking and Floria Bea, who are directly part of the C3 project, Mr. Carl Rush, Dr. Julie St. John, Darrell Fox, Lisa Renee Holderby Fox, Dr. Nell Brownstein, Dr. Caitlin Allen, Paige Manking, many students, and then CHW fellows and advisory chairs, Floria Bea, Arredondo, Gail Hirsch, Jo Lisa Castillo, and also Catherine Hayward and Jacqueline Ortiz. So these many names are just a tip of the iceberg. There were also many networks and organizations that should, in some essence, be seen as the authors of this consensus. We are together always trying to refine the work world that we live in, and this is no different. This is a collaborative effort and hopefully will continue to be so for you. It's been used in many ways, and today we're going to focus on how these core roles and competencies have been used in designing training. I wanted to go to the next slide if I could. This is just to both acknowledge but also to disclose that we have no conflicts of interest as a presenting team. We were grateful for funding from the Amgen Foundation and then from Sanofi US to fund the work of the C3 project, had phase 1 and phase 2. And we were very much, I think, empowered by those funds and not in any way hampered. So I really want to acknowledge that kind of contribution that supports work and allows the field to direct how this work was carried forward. Next slide. So this little triangle is just sort of a building block, I think is really an important one that actually came out of the National Community Health Advisor Study in 94 to 98. And Dr. Noel Wiggins, who led that component of the study, the core roles and competency work back in 94 to 98, really helped us define how we, in the looking at the community health worker roles and competencies, would define them. So when we think of the roles or the scope of practice of a CHW is at the top of the pyramid. What is it that CHWs are actually doing to carry out their work? Are they working in the health education and health promotion role? Are they linking people to services? Are they doing community advocacy? There's many roles they play. And to support those roles, there's a wide number of skills that they need that support many roles. So next we come to skills. But at the heart of the community health worker field is the qualities, the connectedness to communities served that come through qualities. So we think of the skills and qualities together as the competencies that inform CHW work. In the study that we undertook from 2014 to 2018, we looked at first these roles, skills, and qualities, and how had they changed since we'd done this work 20 years prior. So if you see that word contemporary, develop national consensus around contemporary recommendations for core roles and competencies, it was really to bring forward what we had started back in the late 90s when the field was strong and vibrant, but lots of community health worker programs did not know about one another. There were tribal programs, inner city programs, rural programs that had not connected. And we opened the door and said, what is it that you do in your work as community health workers? Tell us all the things. And Noelle was the first person, Dr. Wiggins, taking the pass at coding all that information and identifying the different discrete roles and skills and qualities. But then here 20 years later, when we looked, instead of asking what was different, we now looked at lots of existing content in states and in some select curriculums and said, what has changed since we began in 94 to 98? So not what are all the things that community health workers have in common, but now how has what we put down on paper in 94 to 98 moved forward? What do we need to do to enhance and make sure that our roles and competencies now reflect what's true at this point in history? So that was really the big work of the project, was to bring forward that earlier work. We also decided it would be important to understand if there were differences in the roles, skills, and qualities needed in clinical settings or in perhaps community settings. And actually, we'll not discuss that at length, but can say that we determined that roles and competencies needed to stay the same across settings. And finally, we wanted to look at, so many ways that CHWs are evaluated, programs are looked at for their outcomes, but how are we supporting community health workers individually in doing their best work, and what are the best skills and practices we might bring to assessing the community health worker role? So that was a piece of work done by Dr. Caitlin Allen, and she published some separate things that you can find about that. So again, not a focus today. We're really going to talk about the roles and competencies and how they inform training. This is sort of the history, the origin story. And that is, I think, an important way to understand what the C3 project is bringing. Next slide. So we really also wanted very much to have a distinct feature of this project be the integration of community health worker voices and leadership. And each time I've had an opportunity and an honor to work in the community health worker research and advocacy work that I've done, some through the American Public Health Association, CHW section, but in other ways as a researcher, one of the keys has been to look deeper and deeper in how to bring community health worker voice into the center of the work. And one of the things that was really instrumental in making this project, I think, successful in 2014 to 2018 was not only the consultant and advisors, CHWs who are active team members in the project, but the decision we made to take all the findings we had from analyzing the roles and competencies to CHW networks across the country before we released those findings. So we really wanted CHW-driven findings to be released. So we made that decision to work collaboratively. And we went to many networks to explore that, and I'll discuss that in a moment. Next slide, please. So at the helm, in terms of helping our teams stay on track in both phase 1 and phase 2, were in our first project, we had Ms. Catherine Hayward and Jacqueline Ortiz Miller serve as CHW fellows in our project. And they were able to, in an ongoing way, work with us across many different meetings and sort of help us target and analyze the data we were going to collect, the data we did collect, and the way we shared that information forward. And in the second phase, we were delighted to then pull in an advisory council set of chairs. And in this instance, it was Florida Bayo, who you're meeting today, and many of you know her, and Ms. Gail Hirsch. And, these are both individuals who guided majority CHW advisory committee. And in both projects, phase 1 and 2, had many different advisors who were CHWs engaged in the process, and in next slide, in the review that then took place. So one of the key steps I already mentioned was to reach out from the project to all the networks across the country that we could identify, and 23 of some 40 responded and gave feedback on the proposed roles and competencies. And now let me briefly highlight those. Next slide. So the roles we also think of as the scope of work. Those 1 through 7 really stayed very much the same, with a little bit of language modification from 94 to 98. People are involved in CHW work doing cultural mediation, building individual and community capacity, and even providing direct service like taking blood pressure on some occasions in different settings, having some role that might be direct service observing, clinical changes. Then we saw newly really strongly emerging participation in evaluation research, an active, more expressed role in implementing individual and community assessment. So not just sort of a sub role, which it was in earlier times, but really a sort of an active focus on this role for CHWs. And finally, though you'd think it was probably the bread and butter of community health worker work, in our earlier study, we had not identified the outreach as a core scope of work area, but this came forward in the data in the current C3 project. Next slide are the many skills that support community health workers' work. And I'm sure these will be a much of focus of the discussion in training and capacity building today. And as you can see, many again were present. What has come forward since we released the study in 1998 was more, again, emphasis on individual and community assessment skills, so that people need those skills in order to conduct that role, outreach, and evaluation and research. Now, you might see a lot of overlap between the roles and skills, but one distinct thing that I would say is that if you look at each of these skills, they may have multiple roles that they support. So each role might be supported by all 11 of these roles or skills, a knowledge base, for example, including all the content and public health and related topics that people need to understand. But some of them, some skills, are supporting many roles, and some skills are just supporting a few of the roles. So they're very similar lists, but distinct in their own right. And these are really important, we think, to have community health workers learn about all of these skills across the breadth of their training and capacity building, so that they're able to perform the many roles that they may over a lifetime in a project have an opportunity to play. And then finally, last slide, I want to acknowledge the importance of qualities. As a C3 project, we did not try to deepen work that has already been done by Dr. Noel Wiggins and Sergio Matos and others, but particularly these two advocates and members of this working field that we're a part of, really did important work in moving forward our understanding of qualities. So we endorse that as a part of the C3 project, but we know that that connection to community served as a requirement, as a part of what CHWs do, is a critical element in CHW work, and not indeed sort of an afterthought, but sort of an essential front part of planning a good project, is making sure that those community health workers are coming from the community that is intended to receive their valuable skills. And so this is something that we see as always important to note in any approach to developing community health worker programs. And with that, I want to turn the slides over to my colleague and friend Paige Banking, and she's going to talk more about resources that we've developed and future steps for C3.
All right, thanks, Lee. Hi, everybody. My name is Paige Menking. I am on the NATRA board as a CHW ally, and I just started a new job this week with the National Center for Farm Worker Health, and have been working with CHWs, doing CHW training for pretty much as long as I can remember in my adult life, and have been helping with the C3 project for the last 5 or 6 years or so. So I'm really happy to be talking with you all today, and I'm grateful to Lee for setting up that wonderful context about how we arrived at these really critical roles and competencies that are so important for the work that CHWs are doing. So what I'm going to do for the last couple minutes that we have left is just share a few of the things that you'll be able to find on our website that we think will be helpful to you as you are developing CHW training or trying to figure out how to incorporate the core roles and competencies into the training you already have. So next slide, please, Bernadine. Okay, so the first one that we have is this really lovely checklist. So all of those things you just saw on Lee's slides, we just have written out in a lot more detail in this pretty little checklist form that you can use to review whether you feel like you're covering those adequately in your training program, how you want to use those for your CHW program design, research design, team integration, all of those sorts of things. This is a really helpful checklist to go over to use for advocacy within your organization when you're advocating for the CHW role and competencies. So I will link, of course, to all of these as soon as I am done talking, so you can download these. But that is one of the lovely things that you'll find on our website. And then the next slide, please. So these are it's one video available in English and in Spanish. And I personally use this video all the time in my trainings. It's really helpful for CHW trainings, but also for supervisor training, stakeholder presentations. Anytime that you're trying to describe what a CHW does, what the core roles and competencies are, it really goes over how we arrived at these, what each of them is, and why it's important that we have a clear definition of the roles and competencies for community health workers. So again, those are on our website. You don't need to memorize that YouTube link or try to copy it down right now. I promise I will share them with you momentarily, but those are really great resources as well. And the next slide. The assessment toolkit is very helpful for anybody who's designing a CHW program or hiring CHWs maybe for the first time, or trying to revamp the process of onboarding community health workers. It has really great case studies, a rubric for how you want to do kind of, performance evaluation with the CHWs on your team. It has an orientation checklist, a sample job description, and interview questions. And so these, if you're not directly doing CHW program design, or you're not hiring CHWs, but you're training CHWs, this is a really great way to prepare them for what they might see when they're going through the interview process, and to use this for some of that professional development you might be doing as part of your CHW training. And next slide. We also have some great resources in terms of our final report. And this is the one that has, everything we did from 2014 to 2018. And there's also, if anybody is ever going to go back in person, you can print out this really cool big project poster, an infographic that we made that is really lovely wall decoration, and also allows you to point to the roles and competencies whenever you need. And next slide. So for the last year, we have been working with a group at the University of Texas at Houston School of Public Health, the Maternal and Child Health Training Program there, to really look at what's happening to the roles and competencies since COVID-19. And so our first report for that we released in January, and you can also download that at our website. Really interesting information in there. I would highly suggest you skim through it. Some of the important recommendations for y'all to consider as you're thinking through training today: certainly incorporating COVID-19 into your training, having targeted COVID-19 trainings for community health workers. That includes things about vaccine hesitancy, contact tracing, general kind of COVID prevention and treatment information, but also really thinking about workforce support systems for community health workers. How can you build peer-to-peer and networking groups so that folks really have that support in their work from folks who are encountering really similar challenges and successes. And finally, we are thinking through future directions of the C3 project. I am out of time, but I want to let you know I will be sharing a link in the chat here momentarily. We would love to know what y'all think we should be doing next. It's been 5 years since we found the original findings, and we want to know if it's time for us to review them again, what you think would be helpful when it comes to the roles and competencies. What would you like to see us doing next? So I will put that link in the chat, and we would love to hear your feedback. Or you can email us at info@c3project.org, which is on the next slide, Bernadine. And then there's a lovely picture of Flor too. And I will share all of that again here in the chat momentarily. So thank y'all so much.
Awesome, awesome. Thank you, Paige and Lee, for a wonderful presentation, giving that background and that detail about the C3 project, how important it is, and the components that it takes to really lift it up or even stand it up. And they've done a lot of the heavy lifting for you by preparing some great useful tools that you can absolutely incorporate into what your design is for your community health workers. So right now, so that we stay on time, what I want to do is introduce Odilia Garcia from El Sol, and they are going to give us our next presentation.
All right, thanks Lee, Paige, and Kim J. Awesome. So hello everyone, my name is Odilia Garcia. I serve as the Training Center Director here at Sol. Thank you so much for inviting us to be here today. We are thrilled to be a part of this important discussion and very excited that Nashua has invited us to share and talk more about how our center has incorporated the C3 core competencies in our training center. So a little bit about us. El Sol is a local nonprofit serving the San Bernardino Inland Empire area located in Southern California. The training center will be housed within the nonprofit, and it is my privilege to be managing the center moving forward, especially as more and more organizations seek to employ CHW in both traditional and non-traditional settings. All right. So it's an exciting time for us here at Sol, for our team, for the staff. We are proud of all the work and input that our CHWs have done in helping us develop the mission and vision of our new training center. So the vision of our training center is to facilitate community health worker promotores' capacity to serve as catalysts for change through a holistic and transformative learning approach. Our mission is to enable transformation through relevant blended opportunities that ensure continuous growth in community health worker promotores' identity proficiency as community agents of change. All right, so it's an exciting time for us here at Sol as we celebrate 3 decades serving the community and the tremendous growth and expansion of our agency. El Sol prides itself as an agency built on CHW Promotores de Salud philosophy. Everything we do is with the CHW Promotores de Salud at the center of our approach, and CHWs are the most integral part of our mission. This year, we are celebrating 30 years of serving the community in the Southern California region, so we're very proud of that. With over 15 years of experience developing training and curriculums using the holistic approach and cultural sensitivity as our foundation, we have been able to train over 300 multicultural CHWs throughout the US and have developed over 200 training curriculums on a multitude of topics, ranging from the individual CHW's emotional capacity and personal development, all the way to the policy and systems level. So we're very proud of that. We're also proud to have served and represented the Latino, African American, Native American, and LGBT communities in our work through more customized trainings. So in addition to our internal trainings, we have affiliates that share and embrace our CHW philosophy and who seek the support to build their own CHW capacity. This has given us the opportunity to assist other community-based organizations as well as healthcare organizations. In our 3 decades, we have expanded our trainings to outside of the United States, including Mexico, Colombia, Japan, and now Australia. Our aim is to offer tools and technical assistance for those entities that embrace our philosophy and looking for the support to build capacity. So now I'm going to pass it over to our awesome Executive Director, Alex Fajardo. Thank you.
Thank you, Delia. Hi, everyone. Happy to be here. I'm really excited about this presentation because this has been one of the best experience using the C3. So I want to give you kind of an overview of the integration of the C3 in our training center. So we create this kind of illustration so everyone can understand in a better way our approach. So in this circle on this slide, we want to represent our principles guides. So I want to invite you to think as an ecosystem, and the ring that you see there with different colors represent the 7 principles that influence everything we do inside of the circle. So this is like an ecosystem, and the ring that you see there are going to be seven colors that represents our 7 principles. One of them is the C3 um, component. So each principle has been identified as a result of the 20 years of experience as an essential item that will be governed and lead our training center. So C3 was identified as one of the 7 principles to govern and lead our center model. During the past 3 years, C3 has been demonstrated the most effective approach for core competence for CHWs and define the clear aspects of the skill set of the CHWs. That's why we incorporated. Since 2018, El Sol incorporate the C3 within our ecosystem model that has been easy and clear to evaluate in all of the core competence within our core practice model in the CHWs. So it has been a very good approach incorporating this principle in our RIN, and then we have measured some of the outcomes of the trainings and the approach that we are taking. And then, for example, before the training, only 50 CHWs had confidence in the ability to provide health education. And then at the end of our approach of training, the number went up to 93%. That's a very good increase. Also, we asked about the confidence in the ability to provide informal counseling. 86 of them respond being totally confident at the end of the training, when at the beginning, when we asked, just 12% indicate that they were not confident. So we can see another big outcome of this. So C3 helped to eliminate the inconsistency in regards of CHW trainings or lack of standards. For our training center, the C3 has been helping us to give this structure and give more standard training in our training center. So for all of the reasons that I just mentioned, El Sol embraced the C3 as one of the 7 principles in our ecosystems. Now let's go, and this slide, and the next one, as you can see the principles and the operation in action. So as you see, the ring represents the principles and represent the C3 as one of them. But inside, you can see the operation in action. So through the years, El Sol has learned the importance to foster the CHW's promotores de salud growth beyond of the classroom. Similar to the ecosystem that co-creates and sustain, as an example, a forest of trees, they coexist and co-support each other. This ecosystem guiding principles and operation are designed to function in an independent way to support the growth or our CHWs. So in each section that you can see here, you can see the promotor in the middle, or the community worker who is in the middle of the center of this approach. And you can see each section. So we have selection, supporting system, practice, and we have some nutrients, as if we can see in this operation, and has been developed to foster CHW's promoters growth. Everything that we have been incorporated in our ecosystem is to help the growth of the CHWs. So we can see this as an ingredient that facilitates the enhance of the CHWs in an organic movement with the ultimate goal to support CHWs promotores de salud development and the workforce. This slide, I'm just giving you some an overview, a general overview, how C3 has been incorporated into the principal and operation items that we just mentioned. So for example, we took all of the 11 core competence and we incorporated in each of the operational training system in each of our ecosystem, along with another 6. So we create kind of a C3 as 1 plus the another 6, and we create mm, mm, facilitate and incorporate everything within our operation. So for example, let's put the communication skill. That's one of the skills. The core competence of the C3 is recommended. So we incorporate that skill, the communication skill, for example, in the selection. And let's put as an example the interviewing as one of the ingredients. So we have incorporated some questions to identify these skills when we are interviewing. So everything we have been done through our operation, we incorporate the C3 components. As an example, the same skill, the communication skill, we have incorporated into our coaching as an example. So in the coaching, we also incorporate a training in how to coach other CHWs promotores with the C3. So they develop like a plan, an action plan, and develop a training or an action plan of coaching in how to develop each of the core competence through the coaching as an example. The same thing in practice. So we incorporate each of the C3 core competence in practice. So we incorporate everything, not just in the classroom, but also beyond of it. Another thing that I want to mention is that we customize the training and the plans for each CHW and promoter. So we assess the CHWs with the core competence at the beginning, and we develop kind of an assessment. We define all of the 11 core competence plus all of our 6 other um, areas, and we do the assessment. And based on that, we customize a training for that CHW. So it's a customized approach to enhance the capacity, enhance the core competence for each CHW that comes to our training center. So it has been very powerful. So it's a complex of activities that all of them interrelationship one to another in different way. So implications for El Sol and the CHW's world regarding the C3. So we really want to continue the strength using the C3 items in our center and extend it. And also we want to use the C3 as a common language among CHWs, community of practice, so we can have a collaboration and sharing lessons learned from each other, so we can enhance and learn from one another. And also we want to continue to reflect on the utility of the C3 in diverse settings, because that's a powerful, important part. So we have developed this toolkit that is in process. So C3 gave us the assessment toolkit and the checklist orientation and those toolkits, and we just modify them to incorporate all of the 6 principles, and also to customize for each of the operational. So we have in the process of incorporating, and we have a little, we have been increasing our toolkit, that it's the combination with the 7 principles. So we have some of them, like you can see, self-assessment, peer assessment, instructions assessment, that incorporates not just in the training in the classroom, but also as a holistic approach. So I think that's what we are. Our training center embraces different principles that facilitates an atmosphere of trust, creating a safe space to transform CHWs and promotores and the facilitators. So this is we learn from the promotores, community health workers as facilitators, and they learn and we grow together and promote personal, professional, and community and political change. So I'm happy to be here today to share our experience, how we integrate C3. We're going to be put the link of our video that we have for the training center. And if you have any questions, we are going to be here after the presentation to respond to any questions, or you can reach out to myself or to Odilia, who is the training center director of the of our agency. And then also we provide technical assistance, training, consultations, curriculum development. So thank you for having us. I hope this information is, I know it's quick, but at least give us the big picture on how we integrate the C3 as part of one of the principles that reigns all of we do in our ecosystem of training. Thank you so much. I pass to you to Kim.
All right. Thank you, Odilia and Alex, for an amazing presentation on El Sol and how you operate and what you do and how it's so effective. It's really important to lay down some things for people so they can see it like in real time and practicality as to how it applies to their organizations. Now, I'm the last speaker up for today, and I'll give you a little bit of background about me. My name is Kim J. I'm the Senior CHW Consultant and Trainer with Sinai Urban Health Institute. I've been a part of the Institute for 9 years as a community health worker, doing simultaneous training and building up of programs for community health workers to make sure that whatever role they embark upon, that they are ready to do the work in front of them. Before me, you've heard the great explanations and the core skills and the C3 core competency recommendations, and all of those, how they are embedded into what we do across networks. So it's not somebody doing anything different. We have the same foundational background. Our application process can just be modified based on the audience that's in front of us. So I'm going to speak to building our workforce through core competencies. Next slide, please. So I'm just going to give you a little bit of background about who I represent, which is SUHI, Sinai Urban Health Institute, CROWD, the training portion that I work under through SUHI, which is the Center for Research Outcomes Workforce Development. And I'm going to talk to you about a specific project of how we layered on core skills training to contact tracers during the COVID-19 response. Okay. So a little bit about Sinai Urban Health Institute. We've been actually celebrating 20 years of being in existence. We are a community engaged research arm of Sinai Chicago, which is located on the west side of Chicago in one of our most underserved communities. We deliver community health worker training and consultation and also evaluation. So you can get a three-prong approach when you enlist us for services. We conduct health outreach and the inequities for the communities that we are surrounded by. We don't do cookie cutter innovations or interventions. We do things that are specific to the organizations based on to communities based on the input we receive from communities. Currently funded initiatives focus on social determinants of health. We have breast health, diabetes, asthma, violence interventions, and of course our COVID-19 response. We work with various partners to make sure we get the job done because we know nobody can do things alone. We're going to agree to that. And our organizations, we also document our findings through evaluation processes and with our partnerships and the community members and organizations, we just document these things so that when we're doing these interventions and this work, this can be used by other organizations to apply to what they want to stand up as far as community health workers and programs. And we also provide support through our partners and our research and our training. Thank you. So the mission of SUHI actually is to achieve health equity among communities through excellence and innovation. We have data-driven research, yes, CHW interventions, collaborations, and training. It's so important that CHWs are included in the processes of educating and training community health workers. We know what we have to, as a guide with our C3 core competencies, but the input from community health workers is always so valuable because they bring in the boots on the ground approach that really provides that sort of pull behind the veil of what is to be expected when you start to do community health work. And our trainings have been built upon that foundation. Yes, we have the curriculum to follow and to give us the guide, but the most important part is that community health worker input. And I'll discuss a little further how we actually merge those two in our COVID-19 response. CROWD, as I alluded to before, is a Center for Research Outcomes and Workforce Development. This portion of SUHE was birthed out of the research that we had done with the communities that are in the areas that we serve. And with this input and with our work in the community since early 2000s, we developed and sort of perfected a method of hiring and training community health workers, integrating them into the healthcare systems. And there is a best practice guide that you see here that you can also find on our website, and actually find some great support and tools on how you can do this in your own organizations, as well as our consulting center. The most important part about C3, and also with how we implement our trainings, it cannot be cookie cutter. It has to be something that can be applicable for organizations that do different outreach, because we know community health work comes in various avenues and arenas. Some can be totally focused on advocacy. Some can be focused in the healthcare arena. Some can be focused and actually in the political arena, but community health work is attached to it because of the definition of what it is, and not just the title of the work that you are doing, if that makes sense to you. Okay, next slide, please. And I talk about community health workers. For those who you do not know, community health workers are agents of change. They typically come from the communities that they serve, and they really don't need to have any prior medical experience, because that can be taught to you. But some things that community health workers have are things that are innate to their being and their character that makes them who they are. The compassion is there, the empathy is already there, the desire to help is already there. And when it comes down to training community health workers, we layer on those skills based on what's already there, because you can bring us the person actually, but we can definitely give you the skill set it takes to be an effective community health worker. And we know community health worker is really an umbrella term. It's a term that encompasses all of the activities that relate to community outreach that involve hands-on with community members. And it comes under different names. And what the ones I'm going to speak to today are contact tracers and vaccine ambassadors. When I talk about community health workers, it's more than just an acronym. Actually, it's a way of life, because everybody is not designed to do this work. But if there's a desire that lives there, we can definitely take that blueprint and help to build an effective community health workers with core competencies that really gird you with I don't want to say weapons, but with the tools that you need to do the work effectively. Next slide. I'll talk about our original core skills training, which is really a 40-hour training based on the C3 recommendations, and it's appropriate for CHWs in just about any arena and various settings, anything that you can imagine. Our core skills, again, is not static. What we do is build off the previous cohort. So there are some things about what we offered in training that could be modified and edited. We definitely do, because we don't come with perfection. We come with a blueprint and a platform. And we do it based on popular education, knowing that everybody comes to the table with knowledge and understanding, and that what we provide you is framework, but we can always add to it based on your excellence and your expertise that you bring. The modules that we include in this process are, just to name a few: introduction to community health, collaborating with medical professionals, adverse childhood experience, goal setting, motivational interviewing. And one of the things why I really was a proponent of including adverse childhood experiences in our core skills competencies was because of what community health workers experience in the field, knowing that the person you see before you came from a history, and some of those histories were rooted in some horrifying experiences that they had growing up, and it actually changed the makeup of who they were. So CHWs needed to be aware of that. So when they approached people, they had something in the back of their mind that gave them insight on why some of the illnesses that were presenting were there, or some of the addictions that were there. And the beautiful thing about giving people training is that training can be customized. Again, if you already are just profound in motivational interviewing, there's no need to add that on to your training as well. We will edit that and make sure that the other components are there so that you have a well-rounded training. Mhm. Um, the actual project we're going to talk about is one I'm currently still a part of, that was really, really unique to Chicago, to the Chicagoland area. And what it was, or what it is, I would say, is a collaboration with the Shy Tracing Project. That's a tongue twister for you. So it's through the Chicago Cook Workforce Development and other partners. What we were commissioned to do, it was a project that was funded by the city of Chicago that allowed 31 community-based organizations to hire upwards of 500 contact tracers to address the COVID-19 response. What happened was those contact tracers received the training that they needed to sort of do the jump off of connecting with people and telling them about their exposure to COVID-19. But what we knew they needed to do this job effectively was some of those competencies that are outlined with C3. We knew they needed to connect with people, and we knew they needed to learn how to build trust. And we are in a unique environment where we can't be hands-on. We have to be virtual. So we had to really incorporate how to even emote virtually and how you connect with people virtually. And that was what our role was after they completed their official training through one of our local colleges, Malcolm X College. They came to us for what we called our booster sessions, where we layered on those core skill competencies to make them effective in their role. We chose motivational interviewing to start off because when you're contacting people on the phone to share with them some very to some could have been devastating information. They couldn't just deliver it like you were coming to pick up an order. You had to be able to spend some time with people, even in this virtual arena, to develop a space where they would be willing to share and spend time with you. Because these calls took 30 minutes. And if there was any kind of, pushback, it could have taken longer. So our contact tracers needed to be able to handle those situations. We encouraged them to just be themselves and know that the skills that they came with when they were hired, they already had the foundational work. We were going to help them be even better through the core skills and through those trainings. So we did this through what we call our communities of practice. In our communities of practice, our contact tracers met with us monthly in a large Zoom setting, and we would have oftentimes 300 plus contact tracers in those trainings. And what we were able to do in those community practice were really learn from one another first and foremost. They came to share their experiences in the field, what their challenges were, and as a group, we worked through them. But at the same time, we were also teaching, educating, building, and preparing them for what was to come after the initial contact tracing calls were over, which actually converted to vaccine hesitancy and other things that came along with COVID-19 and its impact to communities. We want to make sure that the contact tracers were prepared to stay in this field even after the initial contact tracing impact was over. Next slide, please, because I want to get through this before we go to our Q&A. Just to tell you about the communities of practice, again, the makeup of it was 2-hour sessions. They were facilitated by our crowd trainers and team members. They were separate than the supervisors because it's important to separate those trainings because in those settings, supervisors can sometimes cause energies not to be as free as they want in their explanations or their desires for additional trainings. So we kept those separate. And also we layered on those core skills during that time. We also offered office hours, which are weekly 1-hour sessions. And again, they are facilitated by our staff of trainers. And also they served as a problem-solving network for the contact tracers and their supervisors, again, which were done in separate entities. They were able to help each other work through those challenges. And as a team, we were able to build professional and personal efficacy within them to do the work ahead of them. Uh, has it been challenging? Yes. Has it been rewarding? Absolutely. And their experiences have been so diverse in what their outcomes or what they felt these sessions had done for them, that some who had total hesitancy about staying in the field or understanding what community health work was change their total outcome and say, wow, I'm a community health worker. I can really do this beyond telling somebody you've been exposed. Absolutely, you can do this, and we're going to help you do that. Next slide, please. Again, I'll just share a little bit of a story, and again, these slides will be available for you. I know I may be fast, but again, I want to get to some of your questions, and I want to spend most of our time answering those. We had, as you know, we're working in a very unique environment when all of our connections are really being made virtually, and to onboard and connect people virtually was definitely something that we did champion in this arena, so much so that they were able, our contact tracers as well as their supervisors were able to use what they've learned not only to connect with the clients that they were serving, but with one another in their virtual environments. And this is just a story to speak to one of the contact tracing supervisors who in these different communities of practice and office hours and even in their own training uh, and meeting times, they just develop a closeness. And when they lost one of their contact tracers, they passed away. And they knew because of these relationships that they developed, that telling one of their staff members about this in this virtual environment probably would not have gone over well with them. But they use that motivational interviewing, they use those problem solving skills that they had learned, and they develop a method to reach out to their colleague to give them this information in a way that would not devastate them, but empower them. Because again, community health work is not only about helping one another, helping those that we serve, but also helping one another. And remember to take care of yourself. I know it's a lot to be said in these few minutes. However, it just really gives you some framework about what you can do with your workers right now who are doing work that could fall under the umbrella of community health work. You can empower them and complete them with a core skills training embedded in these C3 core competencies to give them the proper tools they need to address the population that they're serving. And again, is not just in a hospital setting. It can be in violence interruption. It can be in school settings and connecting students to different social services. So there is a lot to what a community health worker can do and how they can do it. They just need the foundational training to make sure they're prepared and equipped to handle it. And with C3 as a guide, you can do that. And with all the tools that are out there and available, especially with the ones that Lee has shared and Paige, in addition to others from El Sol, you can do this work. So I will end that because I know we have 30 minutes for Q&A, and I want to definitely make sure we have time to do that. The next slide really just speaks to the staffers that assisted me in this process, because again, nobody can do this work alone. Teamwork is always a way to make the dream work. So Bernadine, if you change the slide, yeah. So we have our training staff, which is Fatima Padron, Chandria, May, Jeanette, and Julie. They've been amazing in helping sure we get our contact tracers trained in our CHWs that come through our program. Of course, you can connect with us through SinaiChicago.org or SuhiCrowd.org. And that is it for me. I thank you so much, and I welcome any questions or comments you may have, because I want to make sure you You get the goods. Thank you so much. I turn over to Bernadine.
Thank you so much. This was absolutely informative and wonderful. And we have been having a lot of action going on in the chat. So I'm going to just pick out a couple of questions that were asked. And I am going to start with Savannah Kate. And Nina, if you could help unmute Savannah. Savannah, I'm going to ask your question, and if you have anything to add, please do. And Savannah said, I recently switched from a hospital setting to a youth organization setting. How do I incorporate CHW skills in a community-based youth organization? And that could be for any of our presenters. It wasn't directed towards anyone in particular.
Okay,
let me
go ahead.
No,
Go ahead.
ladies first.
Well, I'll just tell you about one of our approaches. Again, it's about the skill set that it takes to connect. And when it goes to any different setting, those same skill sets follow you. And building upon that to sort of refine those. We had a program that we were using church members to connect with their church community for those who had high blood pressure. And what we did was we gave them the foundational training on high blood pressure and how to do that, but we also layered in how to use motivational interviewing to help get at the deeper root of the problem that was keeping them from not having controlled diabetes. We also layered in goal setting because we wanted to make sure that when you're having these conversations and you're trying to initiate change, you had a platform for how that took place. Those core skills still migrate. It's still relevant to the work that you're doing. It's just the setting has changed, if that makes sense to you.
I just want to add something. I think one of the things that we need to consider is that in order to recruit you can recruit from your community, but you need to recruit people. You need to recruit the attributes of the person, not based on the training. And the training can come after, and we can enhance it. You can enhance skills and training, but not the heart. So that's the important part of the community-based approach. And also recruiting from the community. They live in that community. The youth that live in those communities that you are going to be interviewing, and then being part of the decision making in terms of the programmatic, how we want to do it, so they can be guided on it. I just want to give this, when you are recruiting from the community to do this work, I just want to highlight this.
That's a really great point. And I just wanted to add that when we started the phase 2 of C3, we really wanted to understand, I guess I'd newly landed in a medical school, and I was trying to think, like, how do the medical community connect to all of this? And so we were really looking at this clinical and community setting. And can I share just a momentary graphic here? It's not, so elegant, but it'll help me speak to what I was going to say. And I hope that worked. Do you see this?
Yes,
here?
we do.
I have to credit Rhonda Lay, who helped, we were trying to figure out, like, how do we depict the CHW? Heart in the middle, balancing on both feet, community and clinical needs. But what I wanted to speak to from C3 was working in the process of speaking with people in clinical work, and then community health workers in community settings, and one group, a discussion group, which was crossing the lines. What was really interesting, and this is what these 4 are depicting. You might have someone very much grounded in the community doing community focused work. You might have someone in a clinic doing very clinically focused work. And then you sort of might have people sort of crossing out of community into clinics, bringing people in, or people crossing out of clinics doing outreach. But somehow all these individuals really were informed by that same set of core roles and competencies. And it was quite distinct. And it was, I think it's so easy to think that setting would define things, but actually I'll credit also Lisa Renee Holderby Fox, who when we first started to ask the question, she said, oh no, we're going to find out that what we found out, that it really is in all settings, and we want to prepare CHWs to play all the roles and play all the skills. And I think that we have to look for it in training, and we have to look for it in the programs and services that get designed, and we have to look for it in policy, because policy can, like years ago when we did the National Community Health Advisor Study, interestingly, the social support role or coaching role, where things like, goal setting and all that sort of stuff might be housed. There was a hesitance to put that into policy language, because the thought was that maybe this was like counseling roles and, people of another skill set, and we don't want to infringe and, and this happens with other professions as well. But it's really, I think, important to think of all these roles and all the skills that support them as being in both settings. And I think that Alex as well made that important point about, who is recruited in. It's got to have that quality of connection and be able to serve in both spaces. Some people will be comfortable in one more than another, but it really is this boundary spanning, this person in the middle that, is holding up the space. And I think that's, a great question to ask. How do you cross those lines? And hopefully you do.
Thank you so much to all of you for answering that so wonderfully. There is another question by Starlene Maharaj Lewis, and I apologize if I did not say your last name properly. And I believe this is a question for Paige regarding that toolkit. And the question was, is there coaching support for the toolkit? Cross systems integration, healthcare to school / education?
That's a great question. We don't currently have, coaching support for that, but would love to hear, after you look through it. It's pretty self-explanatory. But if you have questions about it, please do email us, and we can see if we can help answer any of the questions that you have around it. I put the link in the chat earlier to where to download that, but I will drop it in again.
Thank you, Paige. And I also have a question from Lakira Watson. And Lakira asked, I work for a hospital system, and I noticed that as a CHW, I feel limited in how I can help with our mental health patients. What is the most effective way to advocate for CHW intervention in behavioral health within my or any organization? And that's right.
I can jump in quick, I know. One of the things that we have been learning through the years, it's the system who is going to be hosting CHWs needs to be prepared. If not, both sides are going to be frustrated. The system, it could be mental health system or healthcare system, and the CHW is going to be frustrated as the person are getting like, why I cannot do this. So I think that enhancing that capacity of the agency who is hosting the CHWs needs to understand their roles, because sometimes they don't even understand. They hire, okay, because it's good, the money's there, let's hire a CHWs, but they don't understand all of the spectrum from outreach to clinical that can be developed by the CHWs. So I think that's one of the part, training or enhancing the training support for those healthcare providers that may want to implement, and not just the healthcare, but also CBOs that want to host. I just want to give that because I have noticed that needs to be enhance the capacity in order to host and foster CHWs within their own agencies. I just want to provide that as part of the solution.
Absolutely, Alex. And I will also add on that when it comes to I'll just say with community health work, you are presented with so many facets of a person, not just necessarily what you're there to handle, but everything that's about them. And I know first and foremost, a community health worker needs a good advocate within their organization, a champion that would speak on their behalf when there is some pushback from different areas. And when it came to mental health, we knew we encountered this when we were in people's homes. When we were pre-pandemic, we used to do home visits, and we would encounter folks who had, it was obvious that there was some mental health challenges going on. So what we advocated for, and our organization really backed us, we were very fortunate to get that mental health one-on-one training. We are not the the person who actually implements the official mental health training, but we're that liaison or that sort of way station until they can get to professional help. Sometimes what's happening with people is they have nobody to talk to, nobody to listen. And sometimes just having that point of somebody understanding where you are until you get into your professional appointment is a great way to leverage a community health worker. Again, not taking on anybody else's role or position, but just providing just a gateway to that space. So we found it to be very helpful that if we can recognize certain aspects of what mental health looks like, then we can be the liaison to get them into professional care, because sometimes professional care takes 2-3 months and people are going through crisis at that time. So we develop a method of if we identified somebody through their own social determinants of health, like checklist, we would set up a method to even call and check with them weekly until they got into professional care. And again, that comes from advocacy from the organization that you're working for, but also understanding that if you're encountering this on a regular basis, we have to sometimes be advocates for ourselves in our role to say, I've been seeing this too much. Is there a way for me to add on to my training or to my scope of practice as far as training is concerned? So I'm able to even facilitate just to be a liaison until they get into professional care. And again, this is not to interrupt what they would get with a psychologist or a social worker, but it's just to give them a space to land until they can get there, if that makes sense.
Yeah, and if we have a second, I'd love to add on. I think, Kim, what you were saying is so important about having champions in the organization. I also think I see so much importance in training on the core skills and competencies, not only as the framework for what you're training, but also making sure that the CHWs who are going through a competency training understand what their roles and skills are, right? So that they can be advocates in their own organizations for what they should be allowed to do as part of their job, right? So if you're seeing this challenge constantly with mental health, but you're facing roadblocks in your organization, that they're not letting you address that as part of your job. Coming back to the C3 project, coming back to the core competencies or your state's, core competencies, right? And saying like, no, this is a thing CHWs do, I promise. Like, this is part of our job. And there are people doing this all over, and I should be able to do that too. So it's a real helpful tool for advocacy. So yeah, I just wanted to add that.
Beautifully said, Paige.
Absolutely. And someone in the chat, Marugia Patel, also said another solution is to become, as the first HW to become certified in mental health first aid, and that helps give some agency and insight into how to help those patients. And there was one question that was brought up, and it garnered a lot of conversation and other people offering their own advice. And this was from Ella Thomas, and she said, I am trying to develop a career ladder for CHWs in Ohio. Do you have any suggestions? So this might not be Ohio specific, but certainly in terms of developing a ladder for CHWs, if any of you have some advice.
So and I know the panel is full of that, but I'll just go ahead and jump in with what my experience has been. That has been the challenge. That has been the number one thing. What did we do with our community health workers? And some of what has happened within my organization here in Chicago is that we have tiered our CHWs from a 1 up until a 3. And then also, this is what you have to remember. Some skill sets, again, CHWs have that they sort of exhibit when they're, doing their work. You may have someone who's leaning more toward research or more towards advocacy. If you see those budding desires within your CHW, you want to find proper mentorship for them into these roles, because typically a community health worker is not a degreed person. They're life degreed, but not institutionally degreed. So a lot of the roles that they may want to embark upon may require them to have an associate's, a bachelor's, a master's perhaps. But if within the organization there are tiers to how you can elevate or responsibilities can shift to incorporate their skill set being elevated, then definitely you have to really look at that and sort of build it in, because they think of community health workers as like just a one-dimensional kind of entity, but there is so much attached to the work that you're doing that some things do rise to the top, and you can still be a community health worker, but your focus is in advocacy, or your focus is in policy, and then elevate them to those areas that would allow you to, we're going to touch on this little tricky subject, to increase salaries to match some of these skill sets as you develop them, because a lot of CHWs are put in a box, and it's like, oh, you just do this, and that's all you can do. But you can do more, and you do more. And sometimes, and what more times than not, we validate success with a dollar sign. So in a just a small way, when you show somebody they've been doing a great job and you elevate them in their role with a little bit more responsibility, which can come attached with an increase, that is always helpful. But it's about seeing it more than just within the framework of just one role, because there's many facets to what you do in a day. You can deal with mental health, you can deal with social services, you can deal with childcare, all in the span of 30 minutes in one visit. But you can also let some of those skills also rise to the top and become an expert in that area, even under your CHW umbrella.
I think I just jump in and add more sort of thinking forward, as opposed to like somehow concrete examples now. But I do know, even when we did the National Community Health Advisor Study back in the 90s, like San Francisco had like level 1, level 2, level 3 CHWs. I mean, there were places to look where there was some remarkable planning. And I think it's harder in some places than others to create those kind of ladders. But I was thinking some ladders might connect to roles, in the sense that, maybe someone is very strong in health promotion. In another sense, some might connect to skills, like someone is really developing both the role and the skill of being like a strong evaluator, research partner. And then health issues, like for years, different groups have emerged, like occupational health, or different arenas where CHWs could maybe specialize in in asthma, or in an arena. And so as you think about building those different pieces of your puzzle, and think of all the different frameworks that we work within, which is, the issues and the, that you might find some of that within the knowledge base that is part of the set of skills. What we did not analyze this fully, but back in the earlier study, when we looked at the skill set that community health workers had, about 50% of the training and the skills were really content focused. Like, I know about asthma, I know about cardiovascular health, I know about diabetes, and lots of the other stuff was more that broad thing. So of course, thinking about specialties in those different ways might be important. And, I think salaries and benefits, I mean, like salary and benefits. Okay, just say that, like, think what that means to someone. And, one other last piece is, I think we forget that how much capacity is already being developed in the field now, but as community health workers, as the principal, educators, capacity builders, trainers, using popular education, using whatever approaches you all take. But that is another arena that sometimes gets underdeveloped. And, we think of like experts coming in and training, but it's experts growing up and training. And so, I think for this workshop, this is a really important thing to think about and emphasize. And perhaps the assessment toolkit that Dr. Caitlin Allen and Dr. Nell Brownstein, who I wanted to be sure to mention, has been a long part of this family as well, was at the CDC for years. That assessment toolkit was built with a lot of, proactive thinking about what's really, best practice in the country. So it might be a good place to look for, like, what are some benchmarks I might recognize as I look at CHW work, and how could I, use that or some similar guides to help assess, here's competence at the mastery level. I want to make that, help that person rise.
Thank you. And in our last 8 minutes, I'll try to move quickly through a couple of these. This was a question from Mercy Anampu for Alex. And they asked, how do you ensure an unbiased assessment of the core competency knowledge of CHW/promotoras? Is it written or oral or a combination?
Thank you. I think in our I just want to add something about the last question because that connects. As I show you our operational, you can see from practice they come back to the selection and they come back to the. That's what we do. Like the promoter community health workers, they go through through this kind of operation and they become the ones who lead the selection, the ones who lead the support. They are the ones who are doing the training. They are the ones who develop the evaluation tools. That's just like a professional development letter is good. So regarding the question, I think that we develop our approach is a holistic approach. We are more towards the person versus the performance. We want to develop the person and not the performance. It will be the performance will be a result of that. So the assessment that we do, it's a process of different things in different areas and include both oral and also include assessments in writing, also include kind of a practice and then evaluating this person. I think this is a balance that we have to be careful in order to maintain this kind of balance. I think it's a combination both of different parts.
Great, thank you, Alex. And a few people brought up self-care in the chat, and one person was Monifa. And Monifa asked, what about cross competencies in self-care for CHWs? We have a specific interest in helping CHWs care better for themselves so that they can continue to care for others and teach their patients the specific techniques to improve adherence to their care plans. And that's for everyone.
Well, I would say for our community health workers, and this is when I've utilized this approach in the various areas that I've been able to touch community health workers, we have to really schedule that time for us and do our check-ins. We do weekly check-ins just to see where we are mentally, emotionally, a temperature check, and also just a reminder of what is your workload, how are you feeling, and reminding the community health worker to step back and take care of themselves. But sometimes we don't know that we are burnt out until we're burnt out. So having weekly check-ins is very helpful, and having them develop a plan within our monthly CHW meetings that we do have. We go through a self-care process and we ask them, we do art therapy, we write, we do music therapy, we go through meditations, and for the skills that they like the most, they sort of hone those and facilitate those that best fit their environment. But sometimes the caregiver does not realize they need care, and you have to help them stop and take a look. And for those who manage or supervise, that's a part of your role as well, when you're checking in with your community health worker to see how they are, and really encourage them to take that time to take care of themselves. There's so much that you see, so much emotional, um, I hate to call it baggage, but emotional clothes you put on when you're dealing with your client. And it's important to be able to you can take it off. It's okay. If you've done the best you can. It's okay to lay that cloak down and remember to replenish and take care of yourself, and remind yourself that, yeah, I didn't get everything done, but I got a lot done and I did a good job. And we have to make that a part of our vernacular, a part of our everyday plan. I know within our training, we ask people what went wrong, and they can raise their hand and tell you everything that went bad today. But if you ask somebody what went well today, they find it very difficult. So we have to normalize being okay and having a happy moment, and being able to stop and recognize, yeah, I did a good job. I made a good cup of coffee today. No matter how small it is, recognize those small challenges and say, I did good, because maybe yesterday you messed it up. All the coffee grounds got in the pot. But today you did good, and it's okay. So remember to acknowledge even the small successes. And with our supervisors, those who look, even when we look after each other, check in on each other. How you doing? We are our brother's keeper. We have to do that. And it's a part of those C3 competencies. Got that self-care is embedded in there. Check in with one another and recognize those small successes because they make things better and more palatable to deal with when you look at it a little bit differently. And it doesn't happen overnight. It's an everyday adventure. But remind yourself, I put up a thing, I invite them to put up Post-it notes. What did you do well today? And find something to pat yourself on the back about. But you have to remember to take care of yourself. It's a part of your routine, like putting on your glasses or picking up your cell phone. Pick up your self-care. I'm sorry, did I preach a little bit? Forgive me.
It was a great sermon.
Pretty inspiring.
Amen. Keep preaching.
I like your person, building the person versus the performance, Alex. I think that speaks to it. And then it's all the modeling, right? It's modeling that self-care is really what a CHW is doing in community. So yeah, I think that inspiring preaching is good.
Just quick another thing. I think in our end we have a self-emotional assessment because the CHW needs to be emotionally stable in order to do the work, and then sometimes we are just performance. So I think the assessment of emotional is important across the entire ecosystem, like all of the pieces to support the emotional. So I think I encourage to build on that within your organizations, even for yourself. If you don't have this support, how do you have time to reflect yourself, how to manage your stress, how to manage those. I think that's maybe if you don't get it from your agency, create your own movement on this. Invite others after work. Let's go walk. I think that's a power community building from the CHWs. I'm gonna take care of my care. So I just want to give this other idea.
Absolutely. And Gloria in the chat said, self-care is not selfish. It is a priority. You cannot give from an empty cup. So thank you, Gloria. Well, we did not get to all of our questions today, but we are collecting them and we will take a look at them. And I will be sending out the presentations, any links, some feedback forms, and I will also pass these questions around to our speakers and they can answer some of them. And we'll also have that in the send out email. So Kim, I will pass it back to you to close us out. You're on mute. You're on mute.
I just want to thank you, amazing presenters. You came with such a wealth of knowledge and such richness. I've learned a lot today myself. And to all of you who took the time to sit with us and to listen and to glean and to share, it's been a very powerful, growing, motivating moment for all of us. I thank you. I hope that what we shared today was impactful for you and that you can take a piece and put it into action like right away. Just know that you don't have to reinvent the wheel. The wheel is there. The spokes are already in place. Dr. Rosenthal, she is very powerful with that part and sharing the information page. You guys are great. Adelia, Alex, thank you so much. El Sol, it's been a beautiful experience. And I would encourage you to find that time to, again, take care of yourself and start to remember even the small challenges or the small victories that you've made every day. So thank you for joining.
Thank
Have
you
an
so much
amazing
for coming, everyone. Have a great one. And hello to Puerto Rico. I saw we had some people in the chat.
Yes.
Hello.
Bye, everyone.
Bye. Thank you for coming.
Thank you so much, everyone.
Thank you.
Thank you.
Congratulations.